topic of presentation is mandibular reconstructions. Using the following outline: introduction, history, causes of mandibular defect, classification, goals and principles, then timing, TMJ, reconstruction, complication, recent advancement, conclusion and reference. Mandibular reconstruction have changed significantly over years and continue to evolve with the introduction of newer technologies and techniques. Mandibular reconstruction results from resections of benign tumors, malignant tumors, and osteomyelitis or osteoradionecrotic mandibles remain a challenge for the surgeons today. Mandibular defects follow ablative surgeries for malignant tumors of the head and neck regions, impact both form and function, which require a multidisciplinary approach to optimize function and cosmetic outcomes. Comprehensive reconstructive strategies require the restorations of facial dimensions, including the width, the height, and the project. To achieve optimal function and aesthetic results, reconstructive surgeon must be able to replace the skeletal buttresses, restore the external and internal soft tissue envelope, elimination of fistulas, and provide a foundation for dental rehabilitation. The geometric design of the inferior border of the mandible defines the aesthetic contour of the lower third of the face. History-wise, in 1821, von Grafe and Dedrick first proceeded the partial mandibulectomy. Then in 1881, free bone graft was the first method of reconstructing mandibular defect and was initially reported by Van Hewer. In 1989, Martin described immediate reconstruction with prosthetic appliances. In 1897, Patrick used metal bands to restore mandibular continuity, while in 1898, Benedict recommended use of celluloid materials. In 1909, white silverware were used. Shadwa, Olia, and Martins used hard rubber. In 1954, titanium. In 1945, use of metal trays with bones chips. In 1971, Collier and Sina introduced osteocutaneous flaps. While in 1978, Markey and Daniel were the first to report outcomes of free versus composite rib flaps. In 1989, Ukraine introduced the sensate free flap. Causes of mandibular defect: ablative surgeries of oral cancer, removal of odontogenic tumors like ameloblastomas. Then we have surgical treatment of cysts, trauma like traffic accident or assault. Then we have resections following a chronic osteomyelitis. We have also resections of osteoradionecrosis of the mandible. We have gunshot wounds. This is a picture showing a patient with ameloblastoma. This is a picture showing a tumor pre-op, and this is a picture showing post-op. This is also a patient showing a pre-op and post-op. This is a picture. This is the A. We have a pre-surgical extraoral photo of the patient showing reconstruct pectoralis major graft, management of carcinoma of the oral cavity. On B, this is the pre-surgical autopantomograph, that's the OPG, showing a tumor on the lower border of the mandible, which is only the inferior border of the mandible that is left. Most of these teeth have already gone, they are in the tumor. This is C. This is showing a picture of post-operative classification of mandibular defect. Mandibular defect can generally be considered by their location and extent and can be divided into defects involving the anterior mandible, lateral mandible, and the ramus or condyles. Jowa et al. Use a classification system designed to reflect the complexity of the reconstruction. Jowa classification provides aid in classifying mandibular defect and reflect the complexity of the reconstructive problems. Central defect, including the canine, that's from canine to canine, designed a C shape. Then lateral segment, excluding the condyle, designed as L shape. When the condyle is resected together with the lateral mandible, the defect is designed as H shape or hemimandibulectomy. So, permutations of the capital letters. Then we have the C, which is the central, we add the L, which is the lateral, not including the condyle, the H, which is the condyle. So if we are taking LH, that's we are taking the central, including the lateral mandible. If we are taking the HC, that's we are taking the central, including the whole part of the mandible, including the condyle. So we can have LCH, that's the other lateral, right and the left mandible. So we are taking the right lateral mandible, the central, and the other lateral mandible. So if we are taking HCL, it means we are taking the condyle of one side with the central and the lateral of the contralateral side. If we are taking HH, it means the central and the laterals are spared, but the condyles are affected. So the significance of this is that a lateral defect can be reconstructed with a straight segment of bone, whereas a central defect will require osteotomy. The classification was modified to include a soft tissue description as well. T representing the tongue when there is defect on the tongue, then M when there is mucosa involved, and S so when there is external skin defect involved. So this is just a pictorial showing illustration. This is the C when the central, that's from canine to canine, involved. So the L, this is the lateral side of the mandible involved, but the condyle is spared. But when we are taking the H, so the H is like taking from the whole of the mandible, which is hemimandibulectomy. This is also an OPG illustrating the tumor. Look at where the tumor is. It's starting from the 7th, is talking all over it, even including the condyles. So this is the post-operative H. We are talking about the H since the condyle is already involved. It's also another picture. These are all illustrations. This is also another one. This is a clinical picture. Goals of reconstruction. Reconstruction of bone continuity. Restore mechanical stability of the function of mastication, speech, and deglutition are the part of the aims of reconstruction. Reconstruction of osteobulb, a sufficient quantity of cellular cancellous graft material should be placed and firmly fixed into a vascular and cellular tissue bed that is free of contamination. Restoration of bone height to achieve the height so that the face should not reduce in height. Bone maintenance. Maintenance of the bone osticles throughout the life of a patient. Graft show initial bone formation but later go on to resolve between 6 to 9 months. So if a graft can be done and it will resolve later, so it's not part of what we want to achieve. A graft that maintains or increase the radiographic minerals density of up to 18 months, almost always maintain the ossicle throughout the life of the patient. That's what we want. Elimination of soft tissue defect. Unseating force that prevent the cells of prosthesis. Restoration of facial contour. So it's not like they should have a surgery and later on the patient's face is looking one side, maybe deviated to other side. That's not what we want. We want to restore such things. Vascularity of recipient bed. Osteogenesis of transplanted tissue depend on the revascularization. So even if they have done a reconstruction, so the tissue, the blood supply is supposed to be with it. If not, still go back to default. So the timing of reconstruction. Under the timing, we have the primary versus the delay reconstruction. Lawson et al. In 1982 reported a successful rate of 90% for delay reconstruction versus 46% for primary reconstruction. In addition, oral communications of primary reconstruction result in unacceptable high complication rate from infections. So early reconstruction can lead to implant infection, lead to rejection. In 1991, Shockley Weiser and published a retrospective review of 19 patients who underwent primary mandibular reconstruction using reconstruction plate and noted 79% success rate. They concluded that immediate reconstruction mandibular defect using reconstructive plate does not replace the use of free flap, but should be remembered as alternative that offer fast and reliable construction with no donor site morbidity and excellent facial contour. So we are taking the material used for mandibular reconstruction. It can be a prosthetic implant, which can be specific device. It can be t-shirts, wires, or bone plate. Or it can also be formed appliances, which are like stainless steel or chromium cardboard titanium, dimethyl acrylate can also be used, polyurethane can also be used. We have the bone graft. It can be fresh autograft from the same patient. We can take from the ribs, from iliac crest, from tibia, or with tibia to place the mandible, where it can also be treated from the autograft. That's same patient, but it has been taken and kept. That's freezing dried, or it can be radiated or autoclaved. It can be combined alloplast and auto. We can use free or compound plast like iliac crest, scapula can also be used, metatarsals, homograph or autograft. You can combine it together. Prosthetic implants used mainly as a spacing device in immediate reconstructions to span the defect and maintain the positions of mandibular segment for future definitive repair. In 1992, Huda reported that the use of tobramycin impregnated with methacrylate can also be used. The use of titanium hollow osseointegrated reconstructed plate was an attempt to address the failure of the other planting system. This plate is a hollow screw made of titanium with perforations along the screw's body, which allow bone ingrowth and results in increase in plate stability at the bone and screw interface. So it allows the bones to be able to grow in within. Expansion bolts within the screw head allow the plate to be anchored to terrestrial screws. This prevents pressure necrosis of the underlying bone, decreasing the potential for plate failure at the screw bone interface. Pedicles and free flaps may be combined with plate reconstruction for soft tissue supplementation and to minimize the possibility of post-operative complications. Pectoralis myocutaneous flap is the most commonly used pedicles flap in this purpose. Plate is usually placed first, and then the muscular pedicle is then suspended from the plate. Important consideration for using reconstruction plate includes preventing exposure of the plate and the posterior need for the removal using a full thickness pectoralis myocutaneous flap over the full extent of the plate to prevent extents during the radiotherapy. Radiotherapy should be postponed long as possible without compromising the cancer treatment. Whenever available, titanium 2.7mm plate or the titanium hollow plate should be used instead of stainless steel 2.7 is not adequate. Stability of the reconstruction plate in the mandible must be carried out with at least 3 screws before and after. Early plate failure in the first 6 weeks after surgery is most often due to technique variations in plate application, such as far projection and unstable applications of plate, which can lead to soft tissue breakdown and infection. So exposure after 12 to 18 months can occur from resorption of bones around the heart, resulting in plate instability. The knot can be loosened, which can lead to instability of the plate. Methacrylate as a space maintainer in mandibular reconstruction. Methacrylate is reported to be well tolerated by bone and soft tissue. So the stability of methacrylate allows the overlying oral mucosa and skins to heal without delay and wound breakdown. Heat cure methacrylate was originally used in the early 1940s for facial prosthetic, and cold cure methacrylate was reported to be initially used in cranial reconstruction in 1941. This is a methacrylate which is used for the reconstruction of lower border of the mandible. Free bone grafting. Calvaneum, rib, ilium, tibia, fibula, scapula, humerus, radius, all are examples of bones that can be used. Bone graft, consisting of medullary bone and bone marrow, contain the highest percentage of variable osteoblasts. These grafts become revascularized rapidly due to their particulate structure and large surface area. This results in higher percentage of surviving cells after transplantation. Corticocancellous grafts contain both cortical bone and underlying cancellous bone, providing osteoblast cells as well as strengthening. Allogenic mandibular rib or iliac crest has been used occasionally for mandibular reconstruction. The allograft is usually hollow and function as a biodegraded tray for corticocancellous bone grafts or as a supplementation for the autogenous bone graft. The benefit of this method include low immunogenicity of the graft, high concentration of transplanted osteocytes, and complete bioavailability of the tray, with the transmission increases rise to autogenous grafts, which can facilitate osteogenesis. Advantage of free tissue transfer. a wide variety of available tissues, and then we have large amount of composite tissues to match the defect, wide range of skin characteristics, more efficient use of harvest tissue, immediate reconstruction, two-team approach, and we also have improved the vascularity and wound healing. We have low rate of first size is little consequence, potential sensory and motor innervation, and use of osseointegrated implants. Disadvantage demanded. It increased operation time. Yes. Then it increased the flap failure rate. Then function stability at donor sites. Non-vascularized bone grafting is a less reliable technique because high rate of infection secondary to salivary contamination. Vascularized bone maintain an intact blood supply, help the graft to maintain its original volume. Bone remain viable, but no need of replacement. Healing time is shortened. Method of fixation. As we said earlier, they read the ilium. So the myocutaneous flaps, that's the pectoralis major, the sternocleidomastoid, we have the radial forearm, we have the scapula, then we have latissimus dorsi. Pre-flap, we have the ilium based on the deep circumiliac artery, scapula based on the superficial circumiliac, based on the internal mammary artery, radius based on the radial artery and the cephalic veins, fibula based on the peritoneal artery, then ulnar based on the ulnar artery. Pedicle bone, we have the clavicle sternum based on the sternocleidomastoid, rib grafts with the pectoralis major. We have rib bear the serratus branch of the archodorsal artery. Then we have the Cavarian grafts with temporalis versus on the trapezius flap. TMJ reconstruction. The first arthroplasty was made by Jawsome and Burton in 1826. These are the goals: to reduce patient suffering and improve temporomandibular joint function, to reduce disability, to contain excessive treatment and cost, and also to prevent morbidity. Autogenous temporomandibular joint replacement is defined as the construction or reconstruction mandibular ramus, that's mandibular ramus condyle as a unit, the glenoid fossa and the temporomandibular meniscus with the patient's tissue. This is a picture showing the temporomandibular joint, ankylosed mandible. Due to road traffic accident or fall, not treatment, it becomes ankylosed, it's not moving. The goal is restoration of the mandibular ramus length and morphology, normal range of motion and jaw relations, to establish vertical height of lower face, to establish premorbid occlusion, dynamic growth, new condyle, popularized by. The advantage of this is biologically accepted with possessing growth and remodeling potential. The disadvantage that fracture resorption, donor site morbidity, recurrent of the ankylosis. Metatarsals can also be used. This is the second metatarsal phalangeal joint, pedicle dorsal metatarsal artery. Metatarsal phalangeal joint is capable of providing only the rotational movement to the jaw without the ability to translate. Interstitial opening of 25 mm to 30 is a limited movement. Other flap use are sternoclavicular joint graft, fibula-free flap, iliac crest, and coronoid process. This is just a picture showing where they use the fibula to replace a missing part of the mandible. Alloplastic temporomandibular joint reconstruction. In 1940, John Murray attempted to mobilize a patient ankylosis temporomandibular joint by placing a small block of wood between the raw bony surface of the residual mandible after creating a gap at the neck of the condyles. And also in 1990, a German surgeon named Glock reported a total joint arthroplasty with every prosthetic temporomandibular and hip joint that he realized with replacement of monopony and pubis gypsum. Gussel in 1947 used Atalum foils. In 1951, Castigliano and Clinch resurfaced the bones of temporomandibular joint with ankylosis with Vitalium. While in 1952, Smith reported the use of stainless steel in hemiarthroplasty for ankylosis. Benoit et al. Reported experimental and clinical results with zirconium in the temporomandibular joint ankylosis in 1955. In 1960, Harry described replacement of ankylosed temporomandibular joints with prosthesis. That same year, Robinson reported a correction of temporomandibular joint ankylosis by means of artificial stainless steel fossa. Indications for the alloplastic joint reconstruction: ankylosis or ankylosis with severe anatomical abnormalities, failure of autogenous graft in patients who have undergone multiple operations, destructions of autogenous graft tissues by mitosis, then failure of prolapse resulting in severe anatomic joint mutilation, severe inflammatory joint diseases such as rheumatoid arthritis that results in anatomical mutilation of the joint component and function disability. Contraindications: insufficient patient age, lack of understanding on the part of the patient, uncontrolled system diseases such as diabetic mellitus, allergy to the metals that are used in the device to be implanted, active infection at the implantation site, then mental status of the patient, which is very important. The advantages: physical therapy can begin immediately, no need for secondary donor site, surgery time is decreased, can be reconstructed in such a way that to mimic the normal anatomical contour of the structure is to be replaced. While the disadvantage, the cost of the prosthesis is high, the materials wear and failure, skills may loosen with time. Yes, when patient is using the skill may be used due to activity and require replacement, inability to follow up the growth of the patient, especially when it's a young age. Decreasing temporomandibular joint prosthetic system, used as a partial joint of treatment of severe internal derangement, perforation, and ankylosis. The condyle prosthesis is always used in conjunction with the fossa element prosthesis and constitutes total joint replacement. The fabrication of this device, a false joint that is being formed, it have two joints, create like a false joint, so be able to achieve movement. Goals for these processes was to maximize the mating of articular surface, which was accomplished with the spherical condyle head. This design feature allows positioning of freedom of the mandibular component following a fixation of the fossa component in all plates. So the complications, that's the plates of extraoral exposure, intraoral exposure. Also, we have the screw losing, plate fractures, and osteomyelitis, that's infections, varying degrees of defect in shape, position, stability, and function. Secondary deformities may arise from structural instability that occur from infection, osteoradionecrosis, non-union, or fractures of the reconstruction plate, cases in which hardware was used along without bone replacement. Having given a protocol for managing perforations of the mucosa and skin, irrigation of the perforations first, then a two-layer closure is done, considering the use of growth factors to seal the submucosal and dermal tissue to closure, eliminate the dead space in the neck closure and passive drainage of the neck closure. Consider maxillomandibular fixation, administer intravenous antibiotic throughout hospital stay, that's course, provide enteral tube feeding for at least 3 days post-operatively, then perform twice daily mucosal or skin closure lined care, gargling with normal saline, or oral antibiotics for 1 week following discharge from hospital. Recent advancement: tissue engineering. Tissue engineering is an interdisciplinary field that combines and applies the principles of engineering and the life science for the development of biological substitutes to restore, maintain, and improve the tissue function. Biodegradable polymers have been combined with the bovine periosteum to form a new bone. So the transport, this segment of this bone is cut just adjacent to the defect and moved gradually across the defect by a mechanical device. A new bone fills in between where the space is being created, a piece of bone being moved, and this referred to as transport. Medulla endoprosthesis, which is a metallic device that replaces the diseased bone in the long axis and is fixed internally with bone cement within the medullary space of the remaining healthy bones. There is no need for the screw or plate fixation, so there is no need of that. The variable length of the bone graft can be bridged, allow the accurate three-dimensional reconstruction. Then the modules are reconnected by a locking system. In principle, mandible will qualify for such endoprosthesis because of the existing medullary space. So occlusal rehabilitation could be achieved on implants that are screws into the existing holes. So in conclusion, although there are many options for the mandibular reconstruction, vascular bone flaps are unique in which they permit the reconstruction of the oromandibular complex, even though the recipient bed is often salivary contamination and pyroirradiation. In contrast to the non-vascularized bone graft, vascularized bone grafts remain capable of healing to the adjacent native mandible and eventually withstand the loading forces associated with the mastication. So the fibula, iliac crest, and scapular donor site all provide bone stock sufficiently for dental implant in the majority of patients, which has been demonstrated as essential factor for full oral rehabilitation. So these are my references. Thank you.
Some comments about the outline. I think when discussing mandibular reconstruction, more like an operative question. So you should approach it from an operative essay outline, which for me will include an introduction. You can mention a history, then surgical anatomy. I noticed there was no anatomy of the mandible on your slides. So a note on surgical anatomy will have also been helpful. Then indications for mandibular reconstruction, which could have been either from malignancy, either congenital, acquired, malignancies, trauma. That there would have been a better way to classify it. And then you now talk about the various options of reconstruction. And then you talk about the general principles of reconstruction. And then you now speak on each one with its indications, advantages, and disadvantages before you now go to complications, recent advancements, and conclusion. So I noticed that you didn't talk about the surgical anatomy. And then the way you presented it was a bit confusing. You finished talking about the mandibular reconstruction, then you now went to temporal mandibular joint reconstruction, which I feel like you should have just handled together. Then also for you mentioned that primary timing of reconstruction under your principles of reconstruction. You mentioned that primary reconstruction has a poorer prognosis than secondary reconstruction. I just want to know if I'm correct, if that was what
Yes.
you said.
Yes.
That primary has a poorer prognosis.
Especially in the infected cases.
Well, okay, I saw some other materials that actually says the opposite, that secondary reconstruction, which is done at a later time, is actually of poorer functional outcome. So this is either because patients may have developed contractures prior to, and then also may have developed some deformities and contractures prior to the attempt at reconstruction. So based on, because you mentioned the goals was to restore function, which includes speech, degglutination, and all of that. So following secondary reconstruction, there's actually worse functional outcome.
Talking of when there is infection, if you do reconstruction, so the infection can affect the reconstruction you've done.
A clarification on that: immediate or delayed reconstruction. These are decisions you take considering a lot of factors. It's not that you just say delayed is superior to immediate or immediate is superior to delayed. The material you cited, in which we're talking about delayed, have whether 90% success rate, whereas immediate has 46%. That paper was written in 1982. Please check when that document was, that paper was written. It's 1982. That's a very old paper. So you cannot be using that to make judgments now. Even as at then, they were not doing the free osteocutaneous fibula grafts for reconstruction of the mandible. So you can't judge with that. So just as you said, if there is infection in the bed, assuming a patient has gunshots to the mandible and he's lost a segment, that's a dirty wound. You can't be discussing immediate reconstruction. You can't discuss immediate reconstruction there. Whereas if a patient has a tumor and then you can reset and you are sure your margins are free. And then you have adequate soft tissue. The tongue, little amount of the tongue is lost, and then you have adequate soft tissue. You can do an immediate reconstruction. So there are things you weigh on a patient before you decide whether you're going to do an immediate or a delayed reconstruction. By and large, all things being equal, immediate reconstruction will always be superior. If everything being equal, you're exposing the patient to one surgery, he does everything in one sitting. Generally, if you can do immediate reconstruction for most reconstructive surgeries, if immediate reconstruction is not contraindicated, it is usually superior to doing a delayed reconstruction. The arrangement, yes, is actually classically not an operative question. Mandibular reconstruction is actually a very wide topic. I can notice you were actually struggling to bring a lot of information. Just as said, relevant anatomy was completely missing. You talked about the HCL classification, central, lateral, and condylar classification. There are actually simpler ways of doing this.
In addition to the things that have been said, if I still go around your outline, you mentioned after your indications and goals, you did not talk anything about evaluation of the patient. Told us the etiology. There should be a place for symptoms you see and signs. Symptoms the patient will come with and signs. This topic, though, is not classically for the traumatic cases where you may need to resuscitate, but I saw that you added trauma as one of it. So that when you take your history, that will lead to etiology. When you go for the examination will now help you to know which part of this mandible is affected. And then you also examine for possible donor sites, because your planning will start pre-op before you start your planning pre-op, and all this information will help you. So another thing, investigation was also missing from here. What investigation can we do? Apart from the X-ray, I saw you were showing us the phantomograph that would show all the tooth. You'd have shown us that too. And then CT scan. Investigation like CT scan and even Doppler too, when you're thinking about your possible donor site, especially when you want to do free flaps. So investigation was missing. Now, I wanted to also mention that as part of your goals and general principle, the things that will determine your choice, apart from the location of the defect, is you want to know what is it. If it's a tumor, will the patient have radiation? Because patients that will need all those radiation, that way you favor using free flaps for, because those ones will be able to withstand the effect of radiation. You can't go and do, you will not want to do prosthesis or just put grafts when you want to go and do radiation therapy. So those are all the things. So that's one of the things that was missing. Even the general condition of the patient, the age, is it a patient that still have tooth, or is odontulous, there's no teeth again? If there's no, you may not need to be doing or how strong is the patient to be able to even withstand the surgical procedure. So those are some things you think about when you are planning. And then you now mention the options, as you've already mentioned. You mentioned them one by one. One of the options I did not even say, I saw somewhere that I could even leave the TMJ without leaving it is an option without reconstructing it. And then you've talked about immediate and late. And I saw that even for some lateral defects, if the central area is okay, you may consider leaving it. Then where I saw there was a way that the options were arranged. Either I leaving it using the reconstructive plates. You already mentioned reconstructive plates. Whether we're using just we're using flaps, like the bulk, especially when you just want to put a lot of bulk, or you're using free flaps. Now, the bone, I would ask about the bone. I saw somewhere, a question I have is that you mentioned that we can use tibia and humerus. So I want to ask, is it as a homograft, or because I want to assume that it's for cadaveric ones? So I want you to clarify, do you mean in living individuals, and how are you taking the tibia and humerus? Is it a split harvest, or you're harvesting everything? I also want to clarify that all those ones we are mentioning that we use it as freeze dried, all those ones are allograft. They are I believe that they are mainly cadaveric bone that we're using. So that's it. Then one other thing that I saw was missing is that as part of even recent advances is that there are computer assisted design that I can use now in the planning, use it in the planning and even intra-op. When you use it to plan the defect and then possible donor site. When you go in, it makes surgery faster and easier. So those are some things I think that I saw that I need to. So I want you to clarify the use of tibia and humerus for me, where you use them. I forgot to add that all those bone options, when you are talking about the advantage and disadvantage, even if the fibula is one of the ones that is very good, it doesn't have it doesn't have good height. For fibula harvest now, you can have a lot of length, so that even if you are going to do hemimandibular defect, very long, actually the longest bone you can get. Although for the iliac region, it can also get very long. The disadvantage of it is the height, so you need to also consider all these things.
You can also even use the ribs, but when I'm talking about the C shape, at times the shape of what you are reconstructing determine what you can use. Normally, when you use the iliac crest, you can break the bone into pieces so that you can join them together using a reconstructing plate to hold them and the screws. But you can't cut the bone less than 2 millimeters. So when you cut it, when it is too small, it means the screw will not hold it. And when you are using it, we normally use step screw. So the head of the screw can also hold. It helps in holding it more than normal screw.
You've clarified that those tibia and humerus is as allograft. So you've clarified that. That 2cm, I also, in addition, for devascularization too. Because sometimes when you are taking those bone, you are taking as vascularized bone flaps.
Yes.
So if you are taking it, you don't want to devascularize it. So you don't want the fragments that you are breaking it into to be too short.
Yes.
No reconstruction is a reconstructive option for mandibular reconstruction. It's not all of them you do something. It is well described. There are some you just leave. I said that you are not doing anything. The humerus and the tibia talked about, I can't really remember anywhere I've seen where people use humerus or tibia for reconstruction of the mandible when you have a lot more relevant thing to use. Currently, the workhorse flap for reconstruction of mandibular defect is the vascularized fibula osteocutaneous flap. That is the goal. That is more or less the workhorse. It can do virtually anything for you.
Yes.
People have also used the radial forearm, taking a split part of the radial bone with it. But that have a lot of issues. But by the time you take half of the radius, there's very little amount of bone you can take together with that flap.
Yes.
Now, you said a lot of things construction in the mandible,
Yes.
particularly for ameloblastoma.
Ameloblastoma, yes.
Is very common.
Yes.
Very common. Ameloblastoma is very common. You research and you reconstruct.
Yes.
And I know that is not what you do. Going to harvest the fibula is not what you do. So you should sometimes tailor discussions. This may come in your exam. You should tailor discussions to what you people will usually do here that gives good results. And the most common thing we do here is use of non-vascularized bone grafts from iliac crest most commonly. And then you hold it with reconstruction plates.
Wait, yes, sir.
That is 90% of what you will do in this environment is that. You use your reconstruction plates to hold iliac crest graft in place. Luckily, the iliac crest is largely cancellous bone. So it provides a very wide area where you can have revascularization and then you have good outcomes.
Yeah.
Something also did not mention at all is about the ribs. The ribs are also very useful for reconstruction of the mandible. Of use of split rib.
That especially the C part of maybe when you're taking it from canine to canine, that cuff area, that place is the most important one that you want to use.
And that is why the way you should have followed your discussion is the HCL classification is to help you with your reconstruction. It's to give you a guide, that classification. So your discussion should be tailored at C central defects, canine to canine. If I have a central defect, what are the options I should use that would readily work? If I have a lateral defect, what options do I have? If I have a condylar defect or a condylar and lateral, like a hemi-mandibular defect, which options do I have? The HCL classification is subdivided into 8 subunits.
Yes, sir.
Yes, that 8. All you need to do is, for each of those 8, you see what are the 2-3 options that are readily available. 2-3 options that are readily available. That is how to take this, and even you will understand, and everybody listening to you will understand. That is the basis of that classification. The classification is simply to help you know what to use, what to do. So, if I may ask you now, a patient comes and you see a tumor in the mandible, central mandible, canine to canine. How will you reconstruct that defect? Question 1. Please answer. Time is far spent. Have detected the tumor. Margins are free.
When the margins are free, the options are, it means I'm using the C part. So the C part, that's canine to canine. If I can get the rib bone, especially the fifth, I will split it into 2. Then I will use the reconstruction plate. At least in each side, I will have like 3
so
bone on.
You do a rigid fixation. 3 screws on each side simply means you are giving a rigid fixation.
Yes, sir.
So why will you split the rib?
1, I have to create for a bone to take. When I did not split, 1, the thickness is even too thick that I can't use it directly. 2, I have to split it so that I will have
split the rib so that you can expose the what? The medullary component that has cancellous bone, so that you have a wide area that can easily have revascularization. That is the simple reason. And that's why every using of split is superior. The results are better when you split the rib than when you use it in full, even outside the thickness. It is better because once you split it, you create a wider area. You have exposed cancellous bone. That is easy to revascularize than putting a full trunk of cortical bone over it.
Yes.
Have you heard of Price technique? Price technique is simply using a rib, splitting it into 2. I use it to reconstruct the whole mandible from end to end. You split it and then you hold it in the middle, and then one middle to the posterior condylar aspect and the other side to the condylar. Just the ribs alone. So those are the things.
It means the condyle aspect is only the lateral.
Yes.
Okay.
Yes. And then you didn't mention anything about use of costochondral cartilages. Differentiating it because that is actually what you should use in children. You take the costochondral cartilage. The cartilage is covered with hyaline. The end is covered with hyaline cartilage. You can actually use it for reconstruction of the condyles, and then it stays. And then once you take that, you've taken the growth plate, particularly in children where they still grow.
Yes.
As that child grows, that bone grows along with it. In fact, studies will show that if you do that, in fact, some children, that costochondral cartilage that you use to do reconstruction may even grow longer than even the other side. So imagine a child now, a 5-year-old child, and you are doing bone grafts. You think those bone grafts will grow as the child grows? They will not. So use of costochondral cartilage is actually the technique of choice. In fact, for TMJ reconstruction in children and for your hemi-mandibular defect, that's actually this gold standard.
Okay.
Apart from doing the free fibula, if you put a free fibula, once it's vascularized, obviously it's likely going to grow as the child grows once it's vascularized. But the question is, how many centers are you able to do free vascularized flaps? So once you can't do that, there are a lot of other things you can do. Lateral defects can be reconstructed simply with a rib. Once it's a lateral defect, just take a rib there and push it. It stays, and then you hold it with plates intact.
Yes.
Spacers, the most common spacers we use in this environment is K-wire. We're doing ameloblastoma resection. It's K-wires we use as spacers for them. PMMA, methacrylate, cement, bone cement, hydroxylapatite.
Yes, bone cement was missing.
Bone cement are what people use in this environment commonly.
Most of the ones I've seen in this TMJ, especially when it is fibrous, there's a false joint. We'll just cut the bone and make it like a false joint. Go and do the reconstruction of the TMJ.
TMJ reconstruction is one of the most difficult reconstructions to do.
Of the tooth, in the end.
Once
Do you remember that you send the patient so that they can put in implants later?
Rehabilitation, they will do denture for them.
And that's why you actually need good bone stock when you are doing your reconstruction, so that you can get your orthodontist will be able to do a proper dentation for the patient.
We stand masticatory forces.